So I think we are going to start.
Okay.
So today we are going to discuss a nice article. It's talking about effectiveness of beta-lactam monotherapy, macrolide combination therapy for children hospitalized with pneumonia. And it was an honor to work with Dr. Dodd working for this presentation. So first of all, our objectives, we are going to discuss how to choose an article depending upon PICO-TT format that we know, and then then we are going to discuss the article itself, then we are going to appraise it. So the story of this article started, we were looking for the nice article to present, and we are dealing all the time with pneumonias, antibiotics, whether inpatient or outpatient. So the story that when I was new intern in the hospital, I was talking to Dr. Tapp. She is one of our hospitalists. I worked before in Kuwait, and we had like a protocol that for kids less than 3 months old and admitted with pneumonia, and they have like eye discharge. So usually we started the amoxicillin or any beta-lactam antibiotic, and we used to add azithromycin for them. So I asked Dr. Tapp, is this like a new ordinary thing, or it's like a protocol that is being followed here in the United States? She told me not necessarily, and I put this in my mind. I needed also to make sure also to read about an article. Henry also, Dr. Dodd also was talking to me, and he told me that he felt in his medical school that a lot of kids was initiated on both macrolide and beta-lactam antibiotics, so we decided that this will be our article. So, as you know, pneumonia ranks among the top 3 reasons for pediatric hospitalization annually. So the 2 most common other causes is bronchial asthma and bronchiolitis. So pneumonia, asthma, and bronchiolitis are the top 3 reasons for inpatient pediatric hospitalization. Pneumonia accounts for more days of antibiotics because, asthma and bronchiolitis are not treated with antibiotics usually. So we know that guidelines for management of pneumonia recommends narrow-spectrum beta-lactam therapy for both inpatient and outpatient settings. But we know also from medical school that beta-lactams do not possess any activity against atypical bacteria like Mycoplasma pneumonia and Chlamydophila pneumonia. And there was some recent studies, like there are some studies talking that there is importance, other studies are talking that there's not much importance to treat Mycoplasma pneumonia with antibiotics. They said it's like self-limited. There is still equivocal evidence for this. But regardless, macrolides are often used as empirical therapy for pneumonia in children, and they also have anti-inflammatory properties. This is known for them to have anti-inflammatory characteristics away from their antibiotic use. So a study conducted among 29 U.S. children hospitals revealed that around a third of patients, third of hospitalized children with pneumonia still receive a macrolide. So this was our clinical question. So our PICO-TT format, P stands for population. So we needed an article that stands for pediatric population with pneumonia. And intervention, so our intervention was like macrolide combination therapy. And the comparison is the beta-lactam monotherapy only. And outcomes, we said that we will search for something like length of stay, need to admit in PICU, rehospitalization rate, and self-reported recovery. Types of questions. We said maybe we'll see like prognostic study or therapeutic study, but prognostic studies are more easily to be found, and we don't need like a very controlled randomized trial for such a simple question like treating pneumonia. It's more important like if you are treating cancer, something like this, but for antibiotics and pneumonia, prognostic studies can be also good. And the type of study, we were between like a prospective cohort or randomized controlled trials, but we felt that prospective cohort would be enough for this study. So this was the study that was done. So not to be confused, there was like 2 studies. One was I will call it the mother study, which was this one, and one was the daughter study that we took it, that was about the effectiveness of treatment between beta-lactam monotherapy and beta-lactam and macrolide. So this is the mother study. So this was a very big study, was done by the CDC for the etiology of pneumonia in community, and it was called EPIC study. And it was a prospective population-based active surveillance study among children less than 18 years old. This study was done between January 2010 and June 2012, and it was done in 3 children's hospitals at Nashville, Memphis, and I think Utah. So children were enrolled in this is the mother study. So the children, the mother study were enrolled if they were hospitalized with fever, cough, and with radiographic evidence of pneumonia. So children with recent hospitalization, severe immunosuppression, cystic fibrosis, tracheostomy, or alternative diagnosis were excluded from the main study. So what about this is a graph from the main study. They were did great job seeing the etiology of pneumonia. What's important for us is this orange color or beige color. It's indicating the Mycoplasma pneumonia, and as we see, it's increasing with age. So it's very rare, less than 2 years of old, and it's common starting from age of 5. But this is not our scope. This is just a graph from the main study. So now we are going to talk about our study. So what was the inclusion criteria? So our inclusion criteria in our study was talking about empirical antibiotic use. So whether oral or parenteral, it was okay for both. And was classified according to the first 2 calendar days of hospitalization. So they took the first 2 days and see whether the patient received the antibiotic and what are the antibiotics that they received for the first 2 days of admission. So there was 2 groups, B-Lactam monotherapy groups and Macrolide combination therapy group. So the B-Lactam monotherapy, it's one or more. It's one or more. It's not necessarily one thing. It can be 2 of them. But usually it's one. So if there is second or third generation cephalosporin, so ceforexime or cefotaxime or ceftriaxone, but not anti-pseudomonal. And there was also if there is penicillin, ampicillin sulbactam, amoxicillin, and amoxicillin clavulanate. So the other group was macrolide combination therapy. So it was beta-lactam, the above group, associated with macrolide, whether azithromycin or clarithromycin. But mainly it was azithromycin. I think 80% of patients was put to azithromycin. So this was the 2 comparison groups, beta-lactam monotherapy, that we would like to see them, beta-lactam monotherapy and macrolide combination therapy. The beta-lactam monotherapy, they didn't include anti-pseudomonal antibiotics, and as we remember from the mother studies, they didn't include patients with cystic fibrosis. So all the cephalosporins except fourth, and it's only second and third cephalosporins, not including anti-pseudomonal like ceftazidime, for example. It was not included in this group. So the exclusion criteria, so they excluded all the children who didn't receive antibiotics at all, and they exclude also the children that received any other antibiotics except for the other 2 groups that we discussed before. So what did they do for data collection? So they did great job because the main study was to know what's the etiology of pneumonia. So they did a great job taking blood cultures for pneumococcus, doing a group A streptococcal PCR. I don't know how did they do this, but maybe just to exclude causes of fever, because it's not very common cause to cause pneumonia, but they did this also. They did blood tests for 8 respiratory viruses, and they did nasopharyngeal or oropharyngeal swabs for PCR for 13 respiratory pathogens, including the atypical bacteria like Mycoplasma pneumonia and Chlamydophila pneumonia. There was a board-certified pediatric radiologist blinded to demographic and clinical information. They just offered the X-rays for him and tell him whether this is pneumonia, this is not a pneumonia, without giving him any clinical details. And the results of this assessment were not also shared with treating clinicians. So the treating clinicians didn't know anything about the etiology of the pneumonia. After this, also there was a post-discharge survey. The caregivers were interviewed 3 to 10 weeks following hospital discharge for self-reported recovery and rehospitalization. So Dr. Dodd is going to discuss the participant characteristics.
All right, so if you're coming in late, just real briefly, Dr. Boles and I selected a study that was completed about a year ago And it looked at children at 3 different hospitals and the rates of pneumonia and how that was treated, whether that was monotherapy with a beta-lactam or whether it was combination therapy, a beta-lactam plus a macrolide. And this study, like Dr. Boles, I really like the way he puts it. You had the mother study, which was solicited by the CDC, and then within that study, these patient groups were pulled out, and they excluded people like people with a tracheostomy, people with cystic fibrosis, et cetera, and so on. So, and then obviously with a prospective study, there was some difficulty there with the blinding, but the measures that they used, they really were extensive in the type of testing that they did, much more so than you would expect in a normal kid who was hospitalized with upper respiratory infection. And then also to that point, having the radiologist actually, not just an EO radiologist on night call, but people that were specifically board certified in pediatric radiology with no clinical information whatsoever. I'm not sure if we couldn't tell from the study whether they had age and other things like that, but I'm sure there's other factors that you could tell, and saying, yes, there's a pneumonia, or no, there's not a pneumonia. And then they added that into the study. So the types of people enrolled in this study, from that mother study, looking at the daughter study, you had just about 2,000 kids with what they considered a radiographically confirmed pneumonia. 940 of those were excluded. And the reasons why we just talked about, right? Some of those either didn't receive any antibiotics in the first 2 calendar days, or they got something other than a beta-lactam. And then we're going to talk about this momentarily, but you have an unmatched cohort. So you have just under 1,500 that were included in this unmatched. Excuse me. So as you can see there, 43% got beta-lactam monotherapy, and then 16.9%, right, from that overall number, got the beta-lactam plus the macrolide. So about 2/3 got beta-lactam monotherapy from the unmatched cohort. Okay. And then here's just another way of looking at it. Like I said, you got the mother study, the daughter study, the people that were excluded, the unmatched cohort, and then if you look at the bottom, they took that 1,400 or so and brought it down to about 560. So 280 for just the monotherapy, 280 for just the combination therapy. And we'll talk about the reason why that's important. More characteristics of the people included. You had 693 girls and 725 boys, and the age range was 27 months. The interquartile range, so basically you think about that H-type distribution, 25%, 75%, that's where that lands. And then just interestingly, about 1,000 or 73% of that unmatched group had a virus detected with or without bacterial co-detection, which I'm sure doesn't shock you in the slightest. Atypical bacteria was detected in just under 10%, 8.8%. And of the atypical bacteria, as you can see, the overwhelming majority was the Mycoplasma pneumoniae. So this term propensity score matching. So what you're doing with propensity score matching is you're trying to take, you weren't able to have true randomization, right, by saying, okay, we're gonna take all the kids and we're just gonna, pick at random which antibiotics they get. They still allow the clinicians to make clinical decisions. But what you were able to do is to take that unmatched cohort and say, okay, there's an 8-month-old that got an 8-month-old boy, same race, same everything else, and he got a beta-lactam. There's an 8-month-old boy, same race, same background, who got beta-lactam plus macrolide. And that attempts to kind of mimic randomization on the back side of things. So you're creating this subgroup, this sample of people who received interventions that you're able to compare more accurately. And then I kind of just talked about this, but this was a non-randomized observational study, so obviously there's chance for confounding. But this propensity score matching through the use of a multivariable regression model kind of helped adjust for that. And what you're going to see is that cohort, that propensity score match cohort, was really, the results were very similar between that and the unmatched group. So looking at the outcomes, one of the outcomes we looked at primarily was time to discharge. So you can read as well as I can, but basically, whether it was beta-lactam monotherapy or a beta-lactam plus a macrolide, you can tell that the interquartile ranges were similar as well as the median time there. And then, like I said, once you go into the propensity score match groups, so we're going to try to create randomization here by picking these groups. Again, beta-lactam 53 hours versus 55, and then the combination was 62 versus 59. Again, the interquartile range is very similar, and then the mean time's also very similar. Here it is just in a little bit different format. They're looking at hazard ratios, or rather time to discharge. And I'll just draw your attention to, they looked at it as groups, and then they looked at certain other things. So, for example, age greater than 5, the number of participants there. You can see that most of these hazard ratios include 1 in there. And really the only interesting thing that we found is there was some difference between the hospitals. Hospital A, I believe, being Nashville, Hospital B being Labana and Memphis, and then Hospital C being in Salt Lake City, Utah. A little bit higher incidence of asthma and allergies, I feel like, in these two, maybe compared to here. Just something we thought about. And then secondary outcomes, you look at the group of kids that actually were admitted to the pediatric ICU, and you know, a third of those from that group that ended up going were admitted after the first hospital day. But there was really no difference that was significant between the monotherapy group and the combination group. Fortunately, there were no in-hospital deaths, which is a really good thing, obviously. All right, so I tried to bold these to make it easier because, again, there's a lot of text on these slides. But almost 90% at follow-up had recovered from their initial illness. And again, this is a very subjective thing, right? This is caregivers reporting at 3 and 10 weeks on how they're doing. And obviously, rehospitalization is a very binary thing. You're either readmitted or you're not. So that's a much more objective piece of data. Of the ones that had recovered fully, you can see that 87% or so were the monotherapy group and 91% or so were the combination group. And those numbers are obviously very similar and not significantly different statistically speaking. And then there were, of the kids that ended up being back in the hospital, you can see that 5.4 versus 2% were rehospitalized. So a little bit wider number there, but still within normal ranges. So the conclusions that we could draw from this were adding in a macrolide to your already monotherapy of beta-lactam really didn't give you any treatment benefit over just the monotherapy. And whether you looked at the unmatched group or whether you looked at the matched group, the numbers really bear out to be about the same. So, and then even digging a little further, you look at kids that are that have atypical pathogens, the one that are older than 5, right? So Elia showed us this chart showing that your atypical bacteria is increased, you know, as you get older. Those with acute wheezing or needed PICU admission. They were really very similar. So there doesn't appear to be any benefit to adding a macrolide to the beta-lactam, which is, again, very reassuring in this age of trying to practice better antibiotic stewardship. Before we move on to the critical appraisal, I'll just pause and see if anybody has any questions specifically that we didn't address or didn't answer in your reading, or even if you didn't read it, just randomly off the top of your head.
Did they exclude kids who had gotten antibiotics prior to hospital admission?
Yeah, that's a really good question. So, like, say, for example, a kid that came into the PCP and was seen, and you know, Dr. Henschel started them on something, and then they come in, that sort of deal. I don't know the answer to that. And
well, they excluded the patient with previous hospitalization.
Right.
Yeah. Yeah. You said with previous hospitalization. Yeah. So Dr. Boles was trying to answer the question there and saying that we don't believe that they excluded children who had maybe received a course of antibiotics either shortly before or coming into the hospital, but any kids that had been previously hospitalized were excluded. Yes, sir.
So one of the stratifications or subgroup analyses I think you mentioned was detection of atypical bacteria. Was that detection done and known by the physician prescribing the antibiotic before they had already decided what antibiotic to prescribe?
No. The clinicians were blinded. They
yeah.
didn't. Nobody informed them about the etiology of the infection.
But they could still have, you know, clinical judgment on
right.
the age of the child.
Yeah.
What
so
like, stuff like that.
Right. So they obviously were presented with a child. They knew the age. They had access to the medical record, and then of course they had their clinical exam skills. But as far as the results of the testing, the results of radiographs, anything else like that, they were completely blinded to. And so, go ahead.
Second question: what was like the ethical boundary between them just like flipping a coin and saying, "Do you get combination monotherapy?"
So it depended mainly on clinical. Like, you know, there were 4 groups that usually start macrolide. More than 5 years old, if they have severe wheezing, or
then the detection of the bacteria.
And detection of the but actually they started antibiotic because they depended on the first 2 days of admission. So I assume that they started antibiotics on clinical basis, then the results started to work.
Yeah. So, yeah, to expound and to talk on the microphone so anyone listening can hear what Dr. Boles was saying is, the question was more or less, what were the ethical boundaries? Why didn't they just flip a coin and randomly assign to help with randomization? Okay, you get a Macrolide plus a B-Lactam, or you get monotherapy. And some assumptions that we make based on the exclusion criteria are that they were trying to see if the kids who typically would get the combination therapy, such as kids that have atypicals, kids that are older than 5, kids with acute wheezing, or those that end up needing a higher level of care, was there any difference? And to our knowledge, these kids had to have been started within the first 2 days, and they couldn't have been started on anything else. Kind of once they started down that path, they were in that path. There was no, and then if there was something else that changed, then they were excluded. So there was no intention to treat or anything else like that. It would appear. Great questions. Anything else? Okay. So the whole reason we're doing this is to, obviously you could have figured out what we presented there, and you could obviously do this next part as well. But the whole point of Journal Club is to critically appraise and try to figure out how this is going to help us. So looking at the trial, were these results valid? So was the defined representative sample of patients assembled at a common point in the course of their disease? So what do you guys think? You can do thumbs up, thumbs down. That way you don't have to thumbs up. So yeah, like we said, first 2 calendar days of hospitalization with pneumonia, and then there were certain things that would exclude those patients. It was very early in the course of the disease, and it was from 3 different children's hospitals, which means, and it was tertiary facilities, so they're going to get more advanced disease and poor prognosis than maybe patients from primary care. But regardless, to Dr. Dykstra's point, there could have been kids that were started on antibiotics in the outpatient world. It could have altered their presentation. It could have altered their eventual outcome, so that definitely is a confounder. Number 2 was the patient follow-up sufficiently long and complete? Based on, I'm seeing some thumbs up, based on what we saw 3 weeks and 10 weeks, most kids, even with a viral illness, you're going to see some resolution at that point in time. So allowing them to be interviewed at that time following hospital discharge was helpful information. And like I said before clicking on the next button, 3 to 10 weeks should be enough to allow for that follow-up. What are the outcome criteria that we talked about? So rehospitalization and time to discharge and all those things, are those objective criteria versus subjective? And I'm seeing a lot of head shaking yes. We're giving you guys some softballs. So length of stay, plus or minus whether they were in the PICU, and plus or minus whether they were rehospitalized, are very objective, although we do have some patients that get stuck in that weird limbo. Are they admitted? I'm not sure. We need to put it in order. So anyways, that didn't seem to be too much of an issue here. But not all of the outcome criteria were necessarily objective. A caregiver's report, we've all dealt with parents and caregivers of different levels of baseline anxiety, and so their report of how the child or the patient is doing is obviously fairly variable and subjective. And then were the outcome criteria applied in a blind fashion? The quotation mark should help you out there. And it's like, not really. Like we said, there are certain outcomes that are very objective, and those are obvious, but, maybe families didn't know about treatment alternatives, but obviously the prescribing physicians were aware that there were different things that could be done. And then, symptomatology, if the parents know, oh, they got 2 antibiotics, versus 1, could have affected maybe how they felt like their child ended up being treated. And then did adjustment for important prognostic factors take place? Kind of a weird nose-crunching question, but so you look at the subgroups and how those were analyzed and comparing the length of stay across the 4 groups where you had kids with a Macrolide combined, you would think that they might offer the most benefit. Kids older than 5, right? Kids who actually had an atypical bacteria detected, or children admitted to the ICU. So remember, when we looked at those subgroup analyses, there really wasn't a statistically significant difference, leading us to believe that even though you would expect these children would have benefited from having this combination therapy, there were several, the results were similar with that and monotherapy. and here it is in a graph form, right? So, and we talked about how those, and even again, the only other confounder that we thought to look at was the location of the hospitals, and then thinking about location, right? So in the South, Tennessee, lots of pollen and allergies like here versus Hospital C, which is in beautiful, clear Salt Lake City, Utah. Never been, but it sounds awesome. All right, so I'm going to turn it back over to Dr. Boles. He's going to talk about actually what are the results, even though I feel like we're kind of beating it over the head.
Okay. So, the next question is, how likely are the outcomes over time? This is an important question for the prognostic studies, for the cohort studies. So how likely are the outcomes over time? So from the graph, we see the orange line here is only for the beta-lactam antibiotics, and the dark one is for beta-lactam plus macrolide. So we can say that they go together, like there is no difference with the time. Like, you know, we see also the numbers down here. So this is the matched cohort, as we remember, 280 to 80s, and it started to see like around 20% discharged in around first day, 40% around second day, 60% around third day, and 80% around the fourth day is in plateau, and both of them like going with each other. Like there is no big difference, and there is no change over time. Which is, it's very important, like mainly with treatment for cancers. It's more important than antibiotics because like this should be like over years and months. But now, because we are dealing with antibiotics in a prospective cohort study, so this will be over like hours only. But we can see that there is no difference between early and late outcome, and our both arms go coincident with each other. So there is no effect over time. So how precise are the prognostic estimated? So because this is a prospective cohort and observational study, so we depend on the hazard ratio and the confidence interval ratio. So we saw in this study that findings from propensity score matched analysis were essentially identical to those in the unmatched cohort, which gave us like some relief that both unmatched and matched cohort give the same results. So of course, we would like to see a narrow confidence interval because this means that there is like statistically proven outcomes. So this is an example for what should be like, suppose that the hazard ratio is 1.2, so we'd like to see the confidence interval between 1.2 and 1.24 like this. So yeah, so the true effect will be around the 1.2. So what do you think our confidence interval was there? So this is both the hazard ratio for the time to discharge, the primary outcome, and the hazard ratio also for the time, for the length of discharge for subgroup. So what do you think the confidence interval look like? And by the way, the hazard ratio here means here that if the hazard ratio less than 1, this means that there is slower rate of discharge for children receiving combination therapy. Mentioned here, so the hazard ratio less than 1 indicates a slower rate of discharge for children receiving combination therapy compared with monotherapy. So what do you think of the confidence interval? Does it look like? Is it wide? Is it narrow? Is it variable?
No, I don't see it.
Yeah, because 1 is there. Yeah. Yeah, so it's a little bit variable. For example, this one, the hazard ratio was 1, but the confidence interval was talking about like 0.9 to 1.1, which is very good. But for example, the other here we can see for subgroups, one of them is very important for atypical bacteria. So the hazard ratio was 1, but there's like the confidence interval was very wide between 0.6 and there is 1.54 also and 1.9, which is like, this is again the accuracy of the study. So we will discuss also the external validity. So first question, are my patients similar enough to those in the study? What do you think? Thumbs up, thumbs down. Up, up. Yeah, almost, because this is the study is about pediatric patients less than 18 years old with pneumonia, which is our scope as pediatrician. But, so this question is like for discussion. So when you see, because this study was like inpatient for hospitalized patients, so can we extrapolate this to outpatient? Like this is a question for Dr. Reynolds. When you see a study like this, and it's talking mainly about inpatient, Can you like generalize this even to outpatient?
What do you guys think?
Patient in pneumonia, which is like common inpatient, common outpatient.
I think so. These are patients that are being admitted that are sick enough to get admitted to the hospital.
Yeah. Yeah, maybe IV, because inpatient like receiving IV antibiotics, outpatient are receiving oral. Do you think that this can be a confounder? Yeah, this we said that we are going to like raise this issue for discussion between us because we are not sure about the right answer. But as you said, some of you are comfortable like extrapolating this to the outpatient. So what about patients with chronic lung disease and patients with immunosuppression? Do you think that this study has any relation to do with them? Why is that?
Exclusion criteria.
What? Yeah. And was this sample presented in this study, the chronic patient and the immunosuppressed? Yeah, because if you remember the mother study, they excluded cystic fibrosis, tracheostomy, chronic lung disease, and so we cannot apply this study on chronic patients and patients with immunosuppression. So is the evidence strong enough to make an impact on our practice? So do you think for the inpatient groups they are not like chronic or anything? Can we, from this study, can we start changing our practice to just give them beta-lactams only? So what was wrong? So yeah, so we will see here that PICU patients and mechanically ventilated patients and patients with atypical pathogens were underpowered in both matched and unmatched cohort. I will show you the graph that shows. But we noticed that the PICU patients, mechanically ventilated patients, and atypical pathogens were underpowered in both match and the cohort. So what about severe or complicated pneumonia? Also, we noticed that they put some data about the PaO2-FiO2 ratio, which this can give us like a picture how severe is this pneumonia. Because if this number is approaching 300, this means that there is severe pneumonia or complicated pneumonia with ARDS. But the number were high. The number here was the median was 457, and the least number they got was like 423. Maybe most of the patients were like mild pneumonia. They were not severe pneumonia. So can this make difference if you are dealing with a severe patient with like a severe pneumonia with a lot of patches? He's going to be like to develop ARDS. Is this going to change? And there was a question as we know before, that there is anti-inflammatory role for macrolide, especially in patients with chronic lung disease. So maybe these samples were not well represented in this study, so we didn't see a good benefit. So here from this diagram, this is a matched cohort, this is the unmatched cohort area, this is unmatched and this is matched, and the number here is the total number of patients, and the number in brackets here is the percent. So we can see that this is the PaO2-FiO2 ratio. So all of them were high, not even touching the 300, which is like the cutoff for ARDS. And altered mental status were also very low numbers. Like altered mental status can give us like an idea about if it was their hypoxia, was their hypercapnia. So I think most of the patients were mild cases, not very severe. They were underpowered 22, 2, 1, and 1, which is very, I think any number less than 100, it will be underpowered. And this is what we are talking about, the intensive care admission, PICU admission, mechanical ventilation, and atypical pathogens. So you can see that most of the numbers are less than 100. So those subgroups were underpowered in the study. So what about subsequent antibiotic use or duration of therapy? Because you remember in this study, after discharge, they did a survey. It was 3 to 10 days after the discharge. But did they ask about subsequent antibiotic? Like maybe the kids were discharged home in Macrolide and beta-lactam only, but somebody in like outpatient clinic, their PCB, maybe they added something. They didn't ask about this. So this is another point. The study depended on therapy received during the first 2 hospital stay only. Because maybe this was like broadened or narrowed, so it was not a good point in the study. So this combination therapy group patient continue to take both medication. Like, if you are in 2 medicines at home, usually kids like will take 1 medicine, will discard the other. It's like nobody assesses the compliance of the kids. And this is another point. Treatment compliance after discharge was not assessed. So what about fewer symptoms and quicker return to normal activity? Yeah, they asked about like self-well-being and readmission, but nobody asked like how long were you sick after being discharged? Like maybe the kids on the combination therapy, like they have like short symptoms, they coughed for 2 days. Maybe the patient was only in one medicine, on beta-lactam only they had like 2 weeks of cough. Nobody also assessed this point. So our overall conclusions for the study. Actually, from the studies, there is no clinical evidence supporting overall benefit for adding macrolide to standard beta-lactam antibiotics in treating inpatient pediatric patients with community-acquired pneumonia, especially if we added these 2 lines, especially if pneumonia is not severe, and especially if the patient does not have previous significant lung disease. So we added those 2 lines to their conclusions, depending on the appraisal. And those are our references. So any questions?
Good job.